Many firms buy health insurance for their workers, but the amounts paid for insurance might otherwise be paid in salary. In addition, companies withhold from employees' paychecks funds that pay to support two federal programs, Medicaid and Medicare. That provides health insurance to people 65 and older and to low-income or disabled people. In 2011, the average cost for an employee's share of a family plan premiums rose 74% from its 2003 level, from $2,250 to $4,000. Health insurance premiums extract approximately 20% of the annual median family income in 35 states. Employees are frequently unaware of how much is taken from their paychecks to cover health care costs, which rose from 5.2% of gross domestic product, GDP, in 1960 to 17.9% in 2013. The U.S. Congressional Budget Office projects that Medicare and Medicaid spending will increase from 6% of GDP in 2013 to nearly 12% in 2050 at its current pace. In 2010, then-President Obama and Congress passed the Patient Protection and Affordable Care Act, the ACA, which made major changes to the U.S. healthcare system. The act included a provision that businesses with 50 or more full-time employees must provide health insurance to all full-time employees or pay a fine. States were to set up exchanges to make health insurance less expensive for small businesses and individuals by allowing them to enter an insurance pool where healthy and sick people pay the same premiums. With the election of President Donald Trump taking office in 2017, Repeal and Replace of the Affordable Care Act was implemented. Restructuring this entire sector of the U.S. economy may take months, even years, to achieve. In this chapter, we will explore the most pressing healthcare topics to consider and look around the world to find possible solutions. Americans spend more of their tax dollars on public health care than the people in Canada, the UK, or Australia. Who's at fault? Insurance companies? Drug companies? Malpractice lawyers? Hospitals? Or is it more complicated than a simple blame game? Hey, let's find out. In the late 1700s, England had the highest level of income per person of any large country, but the average life expectancy at birth was only 38 years, and 30% of the population died before reaching the age of 30. In 2014, the average life expectancy at birth in the United Kingdom and other high-income countries was around 80 years. Life expectancy at birth in the United States increased from 47.3 years in 1900 to 78.7 years in 2013. The overall mortality rate decreased by more than 25% between 1981 and 2011. The decline in death rates after 1981 was due to changes in lifestyle and advances in new diagnostic equipment, new prescription drugs, and new surgical techniques. Improving health shifts out a country's production possibilities frontier, and higher incomes allow the country to devote more resources to research and development, including medical research. Since 1981, there have been significant decreases in death rates due to cancer, cardiovascular diseases, and diseases of the liver. Rates of death due to kidney disease and diabetes increased slightly because of an increase in obesity. The increase in mortality and decrease in life expectancy in 1918 were due to the severe influenza epidemic of that year, Spanish flu. The health of the average person in the United States improved significantly during the 19th and 20th centuries. Individuals in the United States today are taller, they live much longer, and they are much less likely to die in the first months of life than was true 150 years ago. Over time, people in high-income countries have, on average, become taller, indicating that their nutritional status has improved. In 2012, about 64% of people received health insurance through their employer, and about 10% directly purchased an individual or family health insurance policy from an insurance company. About 36% of people received health insurance through a government program, including Medicaid, Medicare, and the program run by the Department of Veterans Affairs. About 16% of people were uninsured. Note, because some people have more than one type of health insurance, the sum of the values shown here for each category is greater than 100%. Healthcare in America has been through various cycles, from patient-paid fees directly to their doctor, to insurance company payer systems, to health maintenance organizations, HMO. Each had advantages, but in 2010, the Affordable Care Act solidified health insurance company dominance in the marketplace. We still have Medicare, Medicaid, and military health insurance, and some state-sponsored variants. But the employer mandate put in place by the ACA shifted this category of insurance to new levels. In 2012, about 98% of firms employing at least 200 workers and about 61% of firms employing 3 to 199 workers offered health insurance as a fringe benefit. Some health insurance plans reimburse doctors and hospitals on a fee-for-service basis, a system under which doctors and hospitals receive a payment for each service they provide. About 16% of people were not covered by health insurance in 2012. Some young people opt out of employer-provided health insurance because they do not believe the cost of premiums their employers charge is worth the benefit. The uninsured must pay for their medical bills out of pocket. Addressing the problems of uninsured was one of the motivations for the healthcare legislation enacted in 2010. Canada has a single-payer healthcare system, a system in which the government provides health insurance to all of the country's residents. As in the United States, most doctors and hospitals are private businesses, but they are required to accept the fees that are set by the government. As in the United States, doctors and hospitals are typically reimbursed on a fee-for-service basis. But unlike in the United States, doctors and hospitals are required to accept the fees set by the government. Japan has a system of universal healthcare insurance, under which every resident is required to enroll in one of the many health insurance societies, organized by industry or profession, or enroll in the health insurance program provided by the national government. The Japanese system requires substantial copayments, under which patients pay as much as 30% of their medical bills. As in the United States, most doctors do not work for the government, and there are many privately owned hospitals. In the United Kingdom, the healthcare system is referred to as socialized medicine, a health insurance system under which the government owns most of the hospitals and employs most of the doctors. Apart from a small copayment for prescriptions, the National Health Service, NHS, supplies health services without charge to patients. Elective care is a low priority. To avoid waiting lists, more than 10% of the population has private health insurance to pay for elective procedures. The United States is well above the line, showing the average relationship between income per person and healthcare spending per person, which indicates that the United States spends more on healthcare per person than do other countries, even taking into account the relatively high levels of income in the United States. Typically, the higher level of income per person in a country, the higher the level of spending per person on healthcare. Healthcare spending per person in the United States is higher than in other countries. Comparing healthcare outcomes among members of the Organization for Economic Cooperation and Development, the OECD, the United States does relatively poorly in terms of infant mortality. People in the United States are more likely to have complications from diabetes and more likely to be obese. The United States rates well in the availability of medical equipment that can be used to diagnose and treat illness. People in the United States have a lower rate of cancer deaths and a lower probability of dying from cancer before age 75 than in most OECD countries. Difficulties in making cross-country comparisons in healthcare outcomes include data problems, problems with measuring healthcare delivery, problems with distinguishing healthcare effectiveness from lifestyle choices, and problems with determining consumer preferences. Each country has deployed a different solution, each particular to their specific culture and in response to their resources available. Asymmetric information is the core of the healthcare challenge, a situation in which one party to an economic transaction has less information than the other party. That is the core of the healthcare challenge. You know your ailments better than anyone else. If you or anyone else in the situation takes advantage of that insider information, you can use it for adverse selection advantage. As sellers of lemons taking advantage of knowing more about the cars they are selling than the buyers do, the used car market will fall victim to adverse selection, just as the healthcare market does. The situation in which one party to a transaction takes advantage of knowing more than the other party to the same transaction.
Michael, one day all this will be yours.
This?
See this junker? I paid $100 for her. She's got 120,000 miles on her. Transmission shot, bumpers have fallen off. What do I do with her? I sell her. We really should weld these bumpers on, but that takes time, equipment, money. So, we use super glue instead. Go ahead, put it on there.
Won't it fall off?
Definitely.
Isn't that dangerous?
Not to me.
Asymmetric information problems are severe in markets for all types of insurance. Insurance companies provide risk pooling when they sell policies to households. An insurance company can pool the risk of your house burning down by selling fire insurance to thousands of other homeowners. For the insurance company to cover its costs, the total amount it receives in premiums must be greater than the amount it pays out in claims to policyholders. A company that charges premiums that are too high will lose customers to other companies and may be driven out of business. One obstacle to health insurance companies accurately predicting the number of claims policyholders will make is that buyers always know more about the state of their health than do the companies. Therefore, insurance companies face an adverse selection problem. If companies have trouble determining who is healthy and who is sick, they may end up setting premiums that are too low and will fail to cover their costs. If companies raise their premiums, healthier people may drop their insurance. This would lead to an adverse selection problem because policyholders will be less healthy on average than they were before the premium increase. One way to deal with adverse selection is to require individuals to buy health insurance. The Patient Protection and Affordable Care Act, the ACA, beginning in 2014, residents of the United States were required to carry insurance or pay a fine leveled by the IRS. This provision is known as the individual mandate. The insurance market is also subject to moral hazard, the actions people take after they have entered into a transaction that make the other party to the transaction worse off. Moral hazard in the insurance market occurs when people change their behavior after becoming insured. Normally, there are two parties to a transaction, the buyer and the seller. The insurance company becomes a third party to the purchase of medical services because the company pays for some or all of the services. Economists refer to traditional health insurance as a third-party payer system. This means that consumers of healthcare do not pay a price that reflects the full cost of providing the service. The third-party payer health insurance can lead to a principal-agent problem, a problem caused by agents pursuing their own interests rather than the interests of the principals who hired them. Doctors can pursue their own interests rather than the interests of their patients. Because health insurance pays most of the bill for the medical procedures, patients are more willing to accept them. The fee-for-service aspect of health insurance can make the principal-agent problem worse because doctors and hospitals are paid for each service performed, whether or not the service was effective. Insurance companies can reduce, but not eliminate, adverse selection and moral hazard problems by using deductibles and coinsurance. Someone applying for an individual health insurance policy is usually required to submit his or her medical records. Insurance companies have frequently offered limited coverage of pre-existing conditions. Critics argue that by excluding or limiting coverage of pre-existing conditions, insurance companies force people with serious illnesses to pay the entire amount of large medical bills or go without medical care. The companies argue that if they do not exclude coverage of these pre-existing conditions, then adverse selection problems might make it difficult to offer any health insurance policies, or force companies to charge premiums so high as to cause healthy people not to renew their policies. Some goods or services involve an externality, which is a benefit or cost that affects someone who is not directly involved in the production or consumption of that good or service. There are several aspects of healthcare that economists believe involve externalities. For example, anyone vaccinated against a communicable disease protects not just himself or herself, but also reduces the chances that people who have not been vaccinated will contract the disease. People who do not get vaccinated still benefit from other people being vaccinated. As a result, the marginal social benefit from vaccinations is greater than the marginal private benefit to people being vaccinated. Because only the marginal private benefit is represented in the market demand curve, D1, the quantity of vaccinations produced, Q market, is too low. If the market demand curve were D2 instead of D1, the level of vaccinations would be Q efficient, which is the efficient level. At the market equilibrium of Q market, there is a deadweight loss equal to the area of the yellow triangle. As we explore goods and services in the marketplace, consider ideas of rival and excludable goods or services. A rival good means to consider consumption of the good. If you consume it and thereby no one else can consume it, then it is rival. Excludable goods means that when you purchase the good, no one else can consume that particular good. We take a closer look at healthcare through the discussion of economics. Using these considerations, goods and services can be divided into 4 categories on the basis of whether people can be excluded from consuming them or whether they are rival in consumption. A good or service is rival in consumption if one person consuming a unit of a good means that another person cannot consume that unit. Put healthcare into this analysis. Where does it belong? Studying this table, is healthcare a public good like national defense or the legal system? Non-rival would mean one person receiving healthcare would not prevent another person from receiving it. That is not really the case, is it? While you are in the hospital bed, no one else can be there at the same time. Non-excludability? Are people really excluded from getting healthcare if they cannot pay for it? The ACA, passed in 2010, made payment for healthcare mandatory. If you do not pay, you do not receive it. Plus, you are fined through your tax submission if you failed to pay. Really, healthcare fits into the category of a private good, where it is both excludable and rival. President Trump has introduced several changes to make healthcare more available across state lines, thereby increasing competition, making healthcare costs tax deductible, and allowing health-saving accounts that will further allow tax deductions across tax years. Information asymmetries, externalities, and imperfect knowledge combine to create a challenging situation for any government to manage. Consider for yourself, what is the most equitable solution for American healthcare? Also ask yourself, is this positive analysis or a normative analysis question? Here, we see that healthcare spending has been rising in the United States since the 1960s and before that. Healthcare spending rose from less than 6% of GDP in 1965 to about 17% in 2013, and it is projected to rise to about 20% by 2019. When considered as healthcare spending alongside other personal consumption items, healthcare costs have risen at a slower rate than either our spending on goods in general or our spending on durable goods like appliances and automobiles. Now consider how much people in other countries spend on healthcare. Germany and Norway appear to rank at the top of this list at over $5,500 per person per year. But one is missing. Oh yeah, it is the United States. There, we are topping $8,500 a year per person. So, we are topping the world in per-person costs. And not by a little, but by a lot. By 50% more than the next highest countries. Out-of-pocket spending on healthcare has declined sharply as a fraction of all healthcare spending, while the fraction of spending accounted for by third-party payers, such as firms or the government, has increased. This demonstrates the challenges presented by the third-party payer problem in America. As consumers, we are not directly paying for the services we order from our healthcare providers. At the same time, our medical service providers are not paid directly by the patients they serve. The third party is the insurance companies we and our employers pay, and who decides how much each procedure or service will cost. Price negotiations are made within the guidelines of federal rules and healthcare service providers. Notice that patients are not involved in the price negotiations at all. Where is the incentive for the consumer to shop around for the best price for an MRI, a knee surgery, or medications? Lots of pundits point to the extreme costs of paperwork brought on by regulations as the cause of increasing costs. Providers are obligated to enter specific codes for each ailment and corresponding treatment. That costs money. Others point to heavy cost of litigation brought on because ailments are not always alleviated the way patients find reasonable. Big picture? This happens, but accounts for somewhere between 1 and 7% of total medical costs. This percent of expenses have not changed much over the past 25 years. Uninsured patients often seek medical attention in expensive emergency rooms when they would have been better served at lower costs in doctor offices or in ready care clinics. But since they do not have health insurance, they are not granted appointments. That causes expense creep to climb sharply. Cost disease is not specifically unique to healthcare providers, but it carries a definite cost burden. Think of how new technologies have changed how manufacturers make something like a computer. Automated soldering devices, mechanical assembly, and lightweight materials lead to Moore's Law that says that you double computer capacity every 18 months at half the price. Healthcare has witnessed substantial advances in sickness discovery and for some treatments, but ultimately it is realized with one medical service provider visiting with one patient at a time. 40 years ago, a visit with my doctor took 30 minutes, and today it takes half an hour. At the same time, providers have the expectation of salaries commensurate with their extremely long university training programs, tremendously high stress occupations of life and death, and substantial governmental regulations of their occupations. A substantial effect of good healthcare and improved life choices has created a population that has people living into senior citizen status for decades. When we age, we need more healthcare attention. Typically, expensive healthcare attention. Although the aging of the U.S. population will increase federal government spending on Medicare and Medicaid programs, increases in the cost of providing healthcare will have a larger effect on government spending on these programs. Considering this again as an economist, we can find an equilibrium price and quantity where supply meets demand. If consumers paid the full price of medical services, their demand would be D1, and the equilibrium quantity would be at the efficient level, Q efficient. Because consumers pay only a fraction of the true cost of medical services, their demand is D2, and the equilibrium quantity of medical services produced increases to Q market, which is beyond the efficient level. There is a deadweight loss equal to the yellow triangle. Doctors and other suppliers of medical services receive a price, P market, that is well above the price P paid by consumers. Making healthcare an issue of American national priority has gained attention for 100 years, specifically putting the needs of everyone, rich and poor, into the national debate. These debates did not start over the ACA in 2010. President Truman proposed a national health insurance program in 1945. President Clinton proposed a universal health care package in 1993. In both cases, Congress did not agree with the president's plan, and they were not implemented. This debate changed in 2010 when President Obama, with majority in both House and Senate, passed the Affordable Care Act. Several key components of the ACA were promised to Americans that were immediately not realized, like the ability to keep doctors patients liked and choices of levels of coverage. Highly significant became the evacuation of insurance companies from some states because they could not operate profitably within ACA regulations. That left single insurers in certain locations and the loss of market competition to hold costs low. Healthcare premiums shot up 22% on average from 2016 to 2017. In 8 states, costs went up over 30%. And in Arizona, they went up 116%.
Now for more on this, let's bring in Marco Soriano. He's the managing partner of the Soriano Group. Thank you for joining us. Happy New Year.
Same to you.
During the election, Mr. Trump was saying we're going to repeal Obamacare. He walked it back a little bit. Now he's saying we might try to save parts of it. What do you see happening? Repeal or modify?
Definitely a modification of the current ACA would be more appropriate. I think the rhetoric, the political rhetoric that was happening was just part of the campaign. We can all agree on that. But it would be more beneficial to the average American to implement modifications to the plans, to the reform, rather than what he was saying.
What would you like to see saved and what needs to go?
I think the biggest problem that we have with Obamacare is understanding it. There's too many logistical problems. There's 5 categories that will make you a good candidate for it. Then you have 4 different types of plans that you can choose from, where if you choose the lowest premium, you may end up paying the higher deductible. So this is information that should be disclosed clearer to the people, and to make them understand what are the benefits and the pros and cons of this.
Beyond that, though, what about the fact that premiums have been going up? On average, they've been going up in the double digits, things like that. How do you stop all that?
How do you stop it? Well, it's very complicated to say. First, I don't think this is going to happen right away. Donald Trump and his team of advisors should take their time to understand the implications that any changes may cause down the line, because he has so many other plans in place as well. So it isn't as easy as it is said.
Right.
So I would suggest that they take a very close look at these implications rather than making big calls like this.
Well, they are estimating that it will take 2 to 4 years to come up with the full replacement plan.
Yeah, that sounds right.
If they repeal Obamacare early on, but then it takes a full 4 years to replace it, what happens in the interim?
A lot of Americans that are already enrolled would have issues with, if they're sick and seeing doctors, they will have to pay out of their own pockets for these expenses, and that's nothing that we want to do. So they need to think about that a little bit more, I think. And
what about what we're hearing about a death spiral? That's the term that people are using, where the premiums keep going up, and then the coverage goes down, and then you have less competition, and the less competition is making the prices go up even further. Do you think concerns about a death spiral are real?
Yes, I mean, it's possible. The possibility that that could occur, it depends on legislation at this point. That's why I don't think that it would be immediate a change of reform right away into this. Besides the fact that most Americans that have enrolled for 2017 are already in the plan. So you'll have to wait until 2018 to make any proposals that need to be adjusted or accepted in Congress.
Yeah, it's going to be a long process for sure, and we just saw that President Obama is still hoping to stop it. But as Steve Moore said on our show earlier, Republicans are in control right now. Do they have any shot here?
Listen, Obama can say everything he wants. I think there's a lot of haters of the Obamacare plan. There's a lack of information on the ACA, which is really what it is,
right.
PP-ACA. So calling it also Obamacare misleads people to understand where this information is in the internet. Whether Donald Trump or the Republicans are supporting this initiative by Obama, that's a different story, but they should study it carefully because it can implicate a lot into our economy and the plans that we have for the future.
All right. Marco Soriani, thank you so much.
Thank you so much.
When you shop for a car or truck, new or used, you shop around. That is just what we as consumers normally do. Look for the vehicle we like, that serves our needs and is affordable. This basic feature of the economy is pushed aside in much of our healthcare system because of the third-party payer system. Magnetic resonance imaging, an MRI, may cost you $925 or $10,000. But as a consumer, you are not really negotiating that, are you? You have insurance, so it is not really your problem, especially if you've already met your deductible for the year. It seems ridiculous that the basic market structures to find equilibrium from supply and demand curves has eluded healthcare in America. We take a look at one provider who recognizes the need to advertise their costs to consumers when they have not yet met their deductibles. Let's take a look.
It's a new year. That means you start all over with your healthcare deductible. Be smart. Get your MRI from the lowest cost provider and save yourself money. With state-of-the-art technology, First MRI has the equipment and the experienced staff to get your MRI done quickly and comfortably. Look how much you can save by going to First MRI. Best of all, First MRI offers great pricing without sacrificing quality. It's your money. Tell your doctor you want the lowest cost MRI. Insist on going to First MRI.
Market-based reforms are changes in the market for healthcare that would make it more like the markets for other goods and services. Economists who support market-based reforms to improve the healthcare system were disappointed that the ACA did not adopt this approach. One goal of market-based reforms would be to ensure that U.S. firms continue their innovations in equipment, procedures, and drugs. The ultimate bottom line of a modified U.S. healthcare system must be focused on the improvements of how medical care is translated into the health of the American public. That does not mean the delivery of improved treatments. It translates to how Americans improve the overall health of the population. It is about eating healthier meals, living healthy lifestyles, enabling active involvement, while stopping destructive habits of alcohol, drugs, smoking, and high-risk activities. So much of our reduced enjoyment of healthy living is from self-induced destructive behaviors. Only then can we concentrate on our healthcare efforts squarely on the prevention of catastrophic diseases like cancer, multiple sclerosis, leukemia, heart attacks, and stroke. Did everyone pay attention to what I just did? I converted my positive analysis discussion into a normative analysis opinion. In reality, many people make a trade-off between longer lives and drug use enjoyment, between healthier breathing of fresh air and smoking tobacco or marijuana to feel the high of it. People enjoy the fatty foods at fast food markets instead of taking the time to eat a meal from home with low calorie. Those are trade-offs made with short-term benefits, ignoring longevity.